Today we'll be discussing an acute or subacute variety of interstitial pneumonia, that is cryptogenic organizing pneumonia. Although first described in the early 1980s, it became a part of an IIP in the year 2002 by ATS and ARS. The pathologic hallmark of COP consists of whorls of myofibroblasts and inflammatory cells in a connective tissue matrix within the distal air spaces. It can occur in a variety of settings like infection, drug toxicity, etc. It is only in the absence of this condition or inciting factors it is labeled as cryptogenic organizing pneumonia. Previously called as bronchiolitis obliterans organizing pneumonia, that is BOOP. However, the term has become obsolete in order to reduce the confusion between BOOP and BOS. The disease in COP dominates the air spaces and not the interstitium. However, it was justified to include the COP within the IIPs because it is part of a differential diagnosis of other IIPs and because interstitial inflammation and fibrosis may be present in COP. A unique variant of COP known as CCOP, that is cicatrization form, in which loose fibromyxoid connective tissue progresses to dense collagenized scar tissue with preservation of underlying architecture. It seems to affect both genders equally. The mean age of onset is about 58 years. Non-smokers or former smokers may be affected more than the current smokers. The classical presentation of cryptogenic organizing pneumonia presents with flu-like illness, that is with the symptoms of fever, cough and dyspnea. On auscultation, it's mostly clear or there are certain crackles. They are frequently treated with multiple courses of antibiotics before they are being stamped with the diagnosis of cryptogenic organizing pneumonia. Differential diagnosis mostly includes HP, chronic eosinophilic pneumonia, pulmonary lymphoma, and ARDS. There are certain variants of OP like acute fibrinous organizing pneumonia in which there are intra-alveolar fibrin depositions referred to as fibrin balls but without any hyaline membranes. Like OP, AFOP can be seen in association with CTD, HP, infection, or even as a drug toxicity. Likewise, granulomatous organizing pneumonia, that is GOP, can be seen in association with OP with small, poorly formed non-necrotizing granulomas. Cryptogenic organizing pneumonia is basically diagnosis of exclusion because organizing pneumonia can be seen in various infective pathologies. It can occur on exposure to drugs like nitrofurantoin, phenytoin, amiodarone, etc. After occupational exposure like textile diacromane, titanium nanoparticles. In connective tissue disorders, for example, rheumatoid arthritis, scleroderma, SLE, PMDM. Inflammatory diseases like Crohn's and ulcerative colitis. It can also be seen after radiotherapy treatment, particularly 3 to 6 months following treatment for breast cancer. This post-radiotherapy organizing pneumonia occurs diffusely, it's migratory and is highly steroid responsive. In contrast, radiation pneumonitis is fairly well circumscribed, localized and characterized by retracted lung and traction bronchiectasis. It can also be a presentation of lung transplant rejection. uh, it can be seen in bone marrow transplant as a manifestation of transplant rejection, graft versus host disease, or idiopathic pneumonia syndrome. It is also seen in patients of leukemia and lymphomas. It is said that GERD with aspiration may have some role in development of organizing pneumonia. As seen in other IIPs, a restrictive ventilatory defect characterized by a reduction in TLC is generally seen. In some patients, obstructive ventilatory defect can be found. Hypoxemia is generally mild, although in some patients with more infiltrations, severe hypoxemia may be seen. Organizing pneumonia displays a variable imaging pattern in radiology. Many patients are diagnosed with cryptogenic organizing pneumonia when they are not responsive to multiple antibiotics as it mimics infectious pneumonia. Nodular or areas of ground glass opacity and consolidation can be seen. Even fleeting, that is migratory areas of consolidation over time, can also be seen in cryptogenic organizing pneumonia. Peripheral, patchy, and peribronchovascular areas of ground glass opacity and consolidation are the most classical CT finding of cryptogenic organizing pneumonia. An area of ground glass opacity surrounded by a rim of increased density is known as atoll or reverse halo sign. Whenever it is present, it is very much strongly suggestive of organizing pneumonia, but can also be seen in other diseases like vasculitis, certain infections like fungal infection, or even in pulmonary infarction. When the clinical presentation and chest imaging is insufficient for a confident diagnosis, then only lung biopsy is indicated, whether being it transbronchial or surgical. BAL typically shows accumulation of lymphocytes, neutrophils, and eosinophils. The tissue obtained may be insufficient via transbronchial approach, and however, larger tissue samples can be obtained via VATS. As we can see in the picture, the pathology of organizing pneumonia is characterized by intraluminal plugs of inflammatory debris within the alveolar ducts and surrounding alveoli. The plugs consist of buds of granulation tissue along with whorls of fibroblasts and myofibroblasts in a connective tissue matrix referred to as Mason bodies. OP patterns can be seen concomitantly in patients with NSIP or UIP and may in certain patients represent an exacerbation of an underlying ILD. Mild or asymptomatic disease may not require treatment. They are impressively steroid responsive. Nearly 13 to 58% experience relapse. If all the three lung zones are involved, if there is a pathologic evidence of high level of intraalveolar fibrin on lung biopsy, and if there is high neutrophil percentage on BAL, these are the factors associated with increased risk of relapse. However, these relapses are not associated with poorer long-term outcomes and death is very infrequent. Historically, a treatment duration of 6 months was advocated. However, recent studies have shown that uh, corticosteroid use for about 3 months duration is good enough. Macrolide antibiotics and steroid sparing agents such as cyclophosphamide, azathioprine or rituximab has been advised as an alternative immunosuppressant for such patients. There are some subsets of patients who present with a rapidly progressive and fatal form of OP. In such patients, cyclophosphamide has been advised, but it comes with a limit.